Hi, my name is Astrid Salazar. I go to talk about Burosumab therapy in children with X-linked hypophosphatemia. Definition: X-linked hypophosphatemia, a disorder of renal phosphate levels and the most common irritable Frederick's is caused by loss of function mutation in the gene and current phosphate regulation. And there's hormonal X-linking, which resulted in excess circulation fibroblast growth factor 23, FGF23, is the primary regulator of phosphate homeostasis and acts the controlled phosphate reabsorption in the kidney.
X-linked hypophosphatemia, known as XLH, is a genetic disorder characterized by very low levels of phosphate in the blood. This is called hypophosphatemia. XLH has historically been known as X-linked hypophosphatemic rickets or vitamin D resistant rickets. XLH is inherited in a dominant way, by which only one of the two copies of the gene in each cell is sufficient to cause the disorder. It is also linked to the X chromosome, by which a father with XLH will always pass the mutation on to his daughters but not to his sons. A mother with XLH, on the other hand, has a 50% chance of passing it on to their child, be it a boy or a girl. It is also possible for a child to be born with XLH without inheriting the mutation from a parent. In this case, the genetic mutation appears for the first time in the family, and it is called a de novo mutation. XLH affects on average 1 in each 25,000 births and is caused by a mutation in the FEX gene, which exists on the X chromosome, affecting both men and women. The FEX gene is involved in regulating the amount of phosphate in the body. When a mutation in the FEX gene occurs, this leads to an increased concentration of the protein called fibroblast growth factor 23, FGF23. With FGF23 levels increased, the amount of phosphate reabsorbed by the kidneys is reduced and phosphate is filtered out of the body. To understand XLH, it is important to know that two minerals, calcium and phosphorus, are important for the body to be able to form and maintain healthy bones and teeth. Phosphorus exists in every cell of the body and is found in the food we eat and absorbed with the help of vitamin D. In combination with calcium, it's fundamental in forming strong bones and teeth. The consequent lowering of phosphorus in the blood leads to inadequate mineralization of bone, which leads to a range of skeletal abnormalities, physical impairment, weakness and pain. The need for orthopedic intervention to correct bone deformities is common. Dental abnormalities such as spontaneous abscessing and hearing loss can also occur. It is a lifelong disease that has a significant impact on the quality of life. Signs and symptoms of XLH are typically to appear in early childhood, although some manifestations of the disorder are primarily associated with adulthood. The experience of patients with XLH is diverse, even with families, and problems vary in severity, progression and management. A study in family history can help with the diagnosis of an individual and may help in the diagnosis of other family members who may also be affected. There is no cure for XLH. The existing treatment consists of calcitrol, the active form of vitamin D, and phosphate supplements, given in multiple doses per day to compensate for phosphate wasting. This daily treatment is demanding and difficult to follow because of the high frequency, the bitter taste, and the side effects it causes, such as stomach cramp and diarrhea. Currently, new therapies are being developed to reduce the overactivity of FGF23 and thus lowering the loss of phosphorus, reducing the symptoms of the disease. Children with XLH should be closely monitored by a multidisciplinary team coordinated by a specialist paediatrician to prevent and manage the range of symptoms that can occur, whilst adult care varies from rheumatologists, endocrinologists, nephrologists, and often orthopaedic surgeons, among other specialities. It is essential that more doctors know about XLH in order to facilitate the early diagnosis and treatment of people. This prevents irreversible damage that will improve their quality of life. The members of the International XLH Alliance will continue to educate, support, and advocate for the community to better inform society and doctors to speed up the diagnosis so that more people with XLH can be treated effectively and quicker.
Application in the medicine. Diagnosis based of the physical exam, blood tests, and imaging tests, such as X-ray and history. Specific factors considered for the diagnosis included also grow the legs of the slave abdominal, low level of phosphate, a high level of the FGF23 in the blood. Lack of the response of the phosphate levels to vitamin D treatment. Phosphate wasn't in the kidneys, genetic testing for XLH is available and may confirm the diagnosis of the mutation in the defect, but in the necessary for the diagnostic.
Hi everyone, this is Vignesh from Easyway to Learn Medicine. So today we are going to see about X-linked dominant disorder mnemonic. So this type of questions are repeatedly asking in USMLE examination, board examination, or any other license examination. So this type of questions are asking in a direct manner. So what is the syndrome name? So in a direct manner in a step 1 examination. So the mnemonic is X-linked dominant conditions are characteristically inherited less frequently. X-linked dominant conditions are characteristically inherited less frequently. So please follow the underlined line. So X-linked hypophosphatemic rickets, so which is a type of a vitamin D resistant rickets. So we also call it as SLH, X-linked hypophosphatemic rickets, a type of vitamin D resistant rickets. DO, dominant focal dermal hyperplasia, which is occurs in a focal manner, focal dermal hyperplasia. And O, orofaciodigital syndrome, focal dermal hyperplasia, orofaciodigital syndrome. C, Coffin-Lowry syndrome. R, AR, Alport syndrome and Rett syndrome. C, child syndrome, which is a congenital hemidysplasia with ischioform erythroderma with limb defects. We call it as child syndrome, characteristically C. And I, incontinentia pigmenti. L, Lujan-Frines syndrome. F, fragile X syndrome, X-linked phosphatemic rickets, focal dermal hyperplasia, orofaciodigital syndrome, Coffin-Lowry syndrome, Alport syndrome, child syndrome, incontinentia pigmenti, Lujan-Frines syndrome, fragile X syndrome. So this is a mnemonic for X-linked dominant disorders. So thanks for watching. Thank you.
Pro and cons. Pro, Rickett was significantly ameliorated with a main teacher, a Rick severity total score of the 0.9 in the every 2 with dosing group and 1.1 in the every 4 with dosing group. Cons. Adverse events of fever and myalgia and Other common adverse events across the two dosing groups were headache, nasopharyngitis, pain, and are of lead. Also applied in Ecuador. X-linked hypophosphatemia (HLH) will still fall under the category of rare disease. Is the most common form in the heterogeneous group in the inherent disorder now of hypophosphatemia. Rickets its prevalence is 1:20,001. And the Has is origin in the mutation of the PET genes located of the short and the chromosome 22, which cause the phosphate regulation endopeptidase with the homologous name. Conclusion. In children with X-linked hypophosphatemia, treatment with Burosumab improves renal tubular phosphate reabsorption serum for phosphorus levels, linear growth, and physical function, and reduce time and the severity of breaths.
X-linked pedigrees. This is a very challenging topic in genetics that a lot of medical students struggle with, so I'm going to give you my system for identifying pedigrees. Now, if you're watching this video and you're like, what the hell is a pedigree? Well, I guess we should start there. So this is what a pedigree is, right? It's the flow diagram, if you will, that visually depicts how certain traits or things are inherited. And a lot of times on your exams, you might see a practice question that looks basically like this. They'll give you the pedigree and they'll expect you to look at the visual representation of the genetics and infer, based on that visual representation, what the pattern of inheritance is. So you'll have to choose between, like X-linked dominant, X-linked recessive, autosomal dominant, autosomal recessive, or mitochondrial inheritance. And for people that have never taken some time to learn how these pedigrees work, this is a really challenging topic. So in this video, I'm going to give you my system for specifically the X-linked pedigree. So we're talking about X-linked dominant and X-linked recessive. Now, before we get into my system, I guess we need to start with how pedigrees work. And if you already know this, this will be just a very rapid review, but just in case you're starting from square one, this is how things work. So squares represent male and circles represent female. And whether or not the square or the circle is colored in tells you whether or not they are affected. So for example, the square that is colored in black is an affected male, but a circle that is not colored in and appears white is a non-affected female. So if it's colored in, it's affected. If it's not colored in, it's not affected. Squares are males and circles are females. So there's two examples that we're going to do in this video. Here's the first example. If you see this pedigree, the question is, what is the mode of inheritance? So this is example 1. And then we're going to do a second example. Here's example 2, where if you see this pedigree, what is the mode of inheritance? Now, when it comes to X-linked inheritance, there are 2 rules in my system that you should memorize. And if you understand these rules, you'll get every single pedigree question right for X-linked dominant and X-linked recessive. So first I'm going to tell you the 2 rules, and then I'll prove to you that those rules work. And then we'll come back to these examples at the end and illustrate how easy it is to get these questions right if you use my method. So rule number 1 says that in X-linked dominant inheritance, affected daughters get the disease from affected fathers. So I'm going to prove to you that this rule works. So let's look at affected father. Will have 2 daughters, and because this is X-linked dominant, both of his daughters are affected. In the second Punnett square, you see that the X-linked dominant affected father will have 2 daughters, and both of his daughters will be affected. And in the last Punnett square, all the way on the right, you see that the X-linked dominant affected father will have 2 daughters, and both of his daughters will be affected. So this is where rule 1 comes from. In X-linked dominant, affected fathers will. So here are our 2 rules. And this is all you need to know to get the X-linked pedigrees right. Rule number 1 says that all affected fathers will give the disease to their affected daughters if it's X-linked dominant. And rule number 2 says that all affected mothers will give the disease to their affected sons if it's X-linked recessive. So this is my method for approaching these questions. If you memorize these 2 rules, then anytime you see a pedigree, all you need to do is apply these rules to see which one it is. So remember at the beginning of this lecture, I showed you 2 practice questions, and they were 2 pedigrees. Well, let's put each of those pedigrees on top of this slide.